This is the physics behind it. Normally when the X-rays come out of the source, they have this divergent nature. So in a PA view, what happens is when the X-ray comes out, they pass through the back of the patient, as I had already told you, and the heart that lies closer to the anterior chest wall is lying very close to the film which is placed in the cassette. Therefore, when the X-rays pass through the heart and come to the film, there is very little divergence beyond the heart, and therefore there is very little magnification of the heart. Whereas in the AP view, if we see, as the X-rays come out, you can see there is divergence. The heart that is located close to the anterior chest wall is touched by the X-rays, and after crossing the heart, the rays do have quite a divergence before they reach the film screen combination. So what happens is, after crossing the heart, there is a lot of divergence, and the heart that is actually depicted on the film is larger than the actual size of the heart. So the take-home message here is, whenever we interpret an AP view, we should be very careful in calling that the heart is magnified. Now coming to the PA view and the AP view. In the PA view, what happens is the scapulae are well away from the heart, and you can see more of the lung fields on both sides. The heart is usually closer to normal size, and therefore you can easily call it a normal size, and if it is enlarged, you can actually call it an enlarged heart. And as you can see, there is gradation of blood vessels. The blood vessels are not well seen at the apex, but they are seen well at the bottom. This is because it is usually taken in an erect position, and therefore because of gravity aiding, the blood usually tends to flow to the lower zones, and the upper zones has more of gas of oxygen or gas in it. Here in the AP view, you can see that the scapulae are overlapping the lung fields, and you can see less of the lung fields. The heart appears slightly larger. We had explained why. And the clavicle appears foreshortened. But usually what happens is, it is not as easy as we are telling. So the film itself has to have the marking on it as to whether it is PA or AP. But when in doubt, it is internationally accepted to just call a film frontal view if the film already does not have the marking of PA or AP view in it. So coming to the take-home points on PA and AP view, the PA is taken in the standing or sitting, usually the erect position. The scapulae are not overlapping the lung fields. The clavicles are not foreshortened. There is no cardiac magnification. The fundic gas bubble is seen, and the pulmonary vascular gradation is there. This is the fundic gas bubble that is seen. This is aided only because of the erect position of the patient. Now coming to the PA view, what is important is to find out if there is rotation. How do I know whether there is rotation of the film of the patient while taking the image or not? For this, we have to draw a line along the spinous processes of the lower cervical vertebrae and the upper dorsal vertebrae. Another line is drawn from this line to the medial end of the left clavicle, and another one to the medial end of the right clavicle. Whichever of these two lines is longer means that the patient has rotated to that side while the radiograph is taken. Why is this so important? This is because when there is gross rotation, then the lucency of the two lungs may vary, the visualization of the two hyla may vary, and sometimes the blood vessels also may not be visualized well on one side, but they may be visualized well on the other side. Therefore, when there is rotation, our interpretation may actually be limited. So why an erect position is taken while the X-ray is taken? Lungs are more expanded. The pleural pathology is easier to detect. Air fluid levels are detectable. There is a gradient in the vessel size, as we had already seen. But how do we know that it is an erect position? By looking at the fundal air gas shadow. So the lateral view, it is suitable for anterior mediastinal and posterior basal lesions and encysted pleural effusion. In a lateral view, how is it taken? This is the cassette in which the film is placed. The patient is actually standing with his side to the cassette, and the rays actually pass from one side of the patient through the patient and into the cassette, and that is how the lateral view is taken. How do we read the lateral view? How do we know which diaphragm is which? So first is, let us look at the mediastinal structures. The curved structure that we see here is the arch of the aorta, and we know that this is the outline of the heart. Next comes the bronchus. This is the right main bronchus, which is located slightly higher, and this is the left main bronchus that is located slightly lower. Next is the main pulmonary artery that here we can see taking off from the anteriorly located right ventricle. Next, we have the right pulmonary artery that crosses in front of the right main bronchus. and the left pulmonary artery that hooks over the left main bronchus. So these are the most important structures in the lateral view. This is the arch of the aorta. This is the outline of the heart. Right main bronchus, left main bronchus. This is the main pulmonary artery, and then you have the right pulmonary artery and the left pulmonary artery. One more point to remember in the lateral view is that as we come from above below, the lucency of the vertebrae is increasing. That is, the vertebrae which appear brighter higher above should appear darker lower below. If not, then it is one sign which we will be talking about later. So now we have one view here where we see that there is a vertical fluid level. But how was this taken? If this patient was standing, how can there be a vertical fluid level here? Well, in fact, this is not a vertical fluid level, but it is a horizontal fluid level. How was this taken? When we know that the patient has got a minimal effusion on one side, then we make him lie with that side dependent and make him turn on to one side. That is the lateral decubitus position. And we pass the X-rays from behind the patient. They cross through the anterior part of the patient and reach the film screen combination. So when there is an effusion here, this effusion is going to form a level at this level, and you can see that there is a straight horizontal line when the X-ray is taken like this. But when we view the X-ray, we view it like any other frontal view, and that is why we see the vertical line. This is nothing but the lateral decubitus view. This is taken when we suspect a minimal pleural effusion by placing the side of the effusion in the dependent side, or when we suspect a minimal pneumothorax, then that side should be placed as the non-dependent side, and then the similar X-ray is taken.